This is one of the best parts about my job is the survivorship care. So patients come to me usually in the beginning of their journey when they need combined chemotherapy and radiation. So my job really is to get them through that whole process and onto surgery, onto chemotherapy maybe afterwards. Then my favorite part is doing the survivorship talk. So, you know, it encompasses a lot of things, and we'll talk about that. So this is just some things we'll talk about today. What are the trends in cancer survivorship? How did it come to be with the Commission on Cancer? And what are the elements? When we talk about a treatment plan, what is that? And then we'll discuss concerns and prevention strategies specifically in colorectal cancer patients. So who's a cancer survivor? Well, awesome. And really the important point is anybody who's been diagnosed with cancer, and it starts from the time of diagnosis for the balance of the rest of their life. And I like this from the IOM report, which really spurred the whole movement in survivorship, the Lost in Transition of the IOM report. And really, many people finish their treatment for cancer unaware of the heightened risks and are ill-prepared to manage their future. So many things that impacts patients' lives with cancer care.
Oh, can I take a picture? Is that okay?
Absolutely.
Oh,
yeah.
No, I just want to make sure it's okay.
Oh, no problem at all.
And there's always a big controversy. People, on Facebook or whatever, you say no one thinks. A lot of people don't think they're survivors until I don't know when. I mean, well, but what's that? I mean, so I always tell people that you become a survivor the day you're diagnosed, and people just are disheartened that that's not true. They're not a survivor. I mean, they're.
And I think we can, say that if you look at metastatic patients, that we're able to keep alive much longer than we used to. I have patients out there 3, 4, 5 years. You've been surviving that whole time.
Mm-hmm.
So I think it speaks to that point that you're saying. So that's how we define it here, and certainly how IOM is.
Mm-hmm.
So I like to, when I talk about survivorship, I like the cancer control continuum, because it talks about, it's the journey that we're doing in the community with prevention and screening, all the way through diagnosis, treatment, and recovery and survivorship or palliative care of end of life. And survivorship really is that continuum. So I like this slide. Look at this. I mean, the growing number of cancer survivors. And you can see where it's projected to go with millions on the left and where we are now and where we expect to be. There's a lot of factors that go into that. One is the aging population. We have mean age of a person with cancer is about 67, 68, and we have our population is aging, the baby boomers. So cancer survivors by disease group. This, if you look colorectal, it's a little bit hard to see, but it's this right here, this color, and then over here, right here. So we've got the fairly large group, but not near as large as we'd like. And you can see that for men, prostate cancer, and for women, breast cancer. So our aim is to get those numbers higher, of course. But again, we expect an increase in 20 years. There's lots more childhood cancer survivors and an increased population. So survivorship really looks at late and long-term effects. There's a lot of physical things that happen to people during their cancer treatment and afterwards, and also the psychosocial aspects. So we hope to address all of those concerns for patients. So the Commission on Cancer got together and they made this standard 3.3. And what it says is that we need to have a plan to give a care summary to all patients and a plan for follow-up. And we give this to patients that we're treating with curative intent. And that, I think, over time may change, but for right now, that's the standard. And each year, we're required to look at our process and make sure that we're implementing it and we're evaluating and doing it properly. So the Commission on Cancer gave us a timeline that we need to be doing this by these timelines. So this year, we need to do it for 25% of all eligible patients. For my GI group, that is the colorectal cancer patient group. And I think that we will meet that metric this year for sure. And I think quite a bit higher.
What about going back into time for people? So many of us have been surviving for more than just a few years.
Yes.
Can we go back to our provider and say, you know, I want a survivorship plan?
Well, I have done that for some of my patients that we developed our, I think it was last January, I rolled it out for us. But I've had people that have gone back even further for. So I think that you certainly could talk to your provider about that. You know, and that is something we would definitely do here. You know, and it helps our survivorship care plan, I'll talk about it a little bit more, but it's all in the electronic record. And that's actually helped, you know, keep things together in one spot, so it's easy for me to go back and find that. So I'm more than willing to do that for people who want that. So this really was spurred by the IOM report, that 2005 report, the Lost in Transition. And the IOM partnered with the Commission on Cancer, and ASCO also got involved. And they have templates out there, and they have core measures and things that we absolutely need to include in treatment plans. Survivorship models, depending on what institution you were treated at, come in all kinds of different shapes and sizes. A lot of them are led by a multidisciplinary team with doctors and nurse practitioners. Most are disease specific, so we will, tailor to the specific cancer a person has. Some are nurse practitioner led, but here I would say that we're really a collaborative model. I'll put the plan together, but I am lucky to work with really involved physicians who take an active role in talking about survivorship care with their patients. So I schedule a visit with a patient, usually on a day where they've seen their physician, and the doctors pave the way, and I come in more with the formal talk. And I think our doctors do a great job on focusing on these aspects. So the purpose of this really is to coordinate care between the patient and the provider. So what to expect? You know, where were you, and what are the expectations going forward? How do we keep an eye on you? And we need to look at prevention of new cancers or recurrence. It's certainly looking at late effects of treatment. We also, a big component is surveillance. How do we keep an eye for metastases or recurrence or new primary cancers, and just in general checking in at how are you coping and how are you feeling physically. And then we will intervene for any of these concerns as needed. So there's two components. One is the treatment plan summary, and that is really what happened. When were you diagnosed? What stage is the tumor? And what did we do for treatment? And ours are fairly detailed. It'll be what was the pathology report, what chemotherapy did we give, how many cycles, do we have to make any modifications, how much radiation was given, and what type of surgery. And then the second component then is the follow-up care plan. How are we going to keep an eye on you? What tests are we going to perform and when? So we really detail that schedule. And then what can we do for lifestyle preventative behaviors? And then what are these late treatment effects, and what can we do about them? So the minimum requirements, again, it's exactly what I just said. It's what did we all do? And it's a nice document, it pulls together. And patients, it seems to me that a lot of times going through the whole process, it was a bit of a blur. So that when we sit down and we talk, patients often say, oh, okay, that's how this, oh, I remember this now, this is how this happened. It really ties it up in a bow, and people say, I didn't exactly know what I got for treatment, now I do. You're nodding your heads, is that an experience you've had? Yeah, and it helps just, people you're getting through it, and you're just focusing on getting to the next thing, and this is a kind of a processing visit for people. Again, so the minimum requirements for follow-up, and this is, what do we expect? What's the course of recovery? And again, what are we going to be doing? This is pretty much everything that we talked about. But the other thing I like is going forward, what kind of healthy behaviors can we institute? What will make a difference? Genetic counseling is another thing that we do talk about. And is it for every patient or not? And again, I think our physicians do a great job, especially, we really need to look at family history, age at diagnosis, and characteristics of a particular tumor. So I think, physicians these days are very clued in on what's appropriate for genetic testing and not. It's always something to ask if you have questions. And certainly, what does it mean for if you have children and when should they begin screening? So, for colorectal cancer patients, we say follow-up visits every 3 to 6 months for 3 years. And that, we always start off usually with 3 months visits. At a certain point, we may transition longer. Sort of a dealer choice. How comfortable is the patient? Where's the provider at? And then every 6 months for 2 years, and sometimes those can be extended to yearly as well. A CEA blood test, which is a tumor marker, is also done every 3 months. CT scans of chest, abdomen, and pelvis yearly for up to 5 years. And then a colonoscopy a year from surgery.
I have 2 questions.
Mhm.
What is your recommendation currently for first colonoscopy for children, offspring?
So usually we say, so if you have children, it's the age at which you were diagnosed, and then 10 years before that they should
Okay,
start.
I've heard some recommendations even younger than that.
My doctor, because it was my grandmother, and there's like 4 people in my family, so when my doctor said 20 and I was diagnosed with 40, I mean, that might be very aggressive, but 10 is the standard. Yeah.
Mhm.
Is that right? So for certain genetic conditions, we would start sooner potentially, but barring some obvious Lynch syndrome or FAP or attenuated FAP, it would be 10 years before the next case the patient is diagnosed.
But it seems like, depending on what your
Or
stage
50,
was,
whichever comes
yeah. I mean, your stage 4, presumably it had been in your system a lot longer than your stage 1, for example.
Yeah, we don't modify based on stage of diagnosis.
Oh, the other question was,
Mhm.
so what do you recommend doing, if anything, after 5 years? I mean, many of us were past 5 years, basically after 5 years, we had our last CAT scans, we had a clean bill of health, we're pushed out of the nest and told, do good things
Mhm.
and don't bother us anymore.
Right.
Is that what you do here, or do you have something that really tracks you through the rest of your life, however long it might be?
We push out of the nest. But, I think it's a comfort zone with the patient too. And I think what we do try to push out of the nest.
We do.
Yeah.
I mean, so oncologists have a work shortage. We don't have enough oncologists around.
So we shouldn't bother our
But colon
oncologists.
cancer almost never comes back beyond 5 years, right? So in breast cancer, we keep them forever because there's always that risk. In colon cancer, it drops pretty substantially.
Drops quite a
Mary,
bit.
can you go back to
3
your
years.
last slide too?
Yeah.
Because you mentioned, it's not, I think that point about the primary, I mean, the studies that I've seen said that sometimes because oncologists are holding up for a while, like what is it, that some of, in dramatic cases, it's only 10-20% opportunity for new patients.
Right.
So, I mean, part of what this treatment summary and care plan is supposed to do is really that transition, and then that bridging back to primary care is really the name of the game for you, right?
It is, and one of the nice things I like about our electronic care plan is I route this summary to the primary care provider. So they know what the schedule is and what we've told the patient. And in those folks that aren't linked up with Epic, I fax it to them with a little, with an introductory letter saying, here's, your patient's completed treatment, this is the summary they've got, take a look at this. And I've gotten feedback from the primary care doctors in the community. They like it. And I do try to remind my patients that you've got to still keep in touch with your primary care doctor because they're going to be looking at cholesterol screening. You're going to be looking at, if you're a male, PSA checking. There's all these other things that they focus on, other health issues. And so I think that's that is an important part that you bring up, is to keep the primary care doctor linked in.
So one of the things, and I'm just also, you know, kind of wearing this hat of like, what role are we gonna play, I think, in advocates and thinking about the research advocacy meetings and where we're going, is I think there's a lot of potential to try to help, you know, like foster additional research in this area, or like looking at moving resources so that primary care really does start to consider. I mean, I think your chart is showing that number of people. I mean, cancer is now a chronic condition, just as much as diabetes or asthma or, you know, what have you.
Yes.
So we're really, I think, part of the lobby and part of our work has to be really making sure that that primary care are in that group is really, because the truth is, I mean, you know, you probably can't hold on to everyone forever, nor is it, like, to your point, I mean, if somebody's not being a quarterback of the team, Aaron Rodgers, then, you know, like, who's gonna really, like, figure all of it out? And the primary care seems kind of to be one of the best spots.
They're in the center of the hub, and once we transition out, they, yeah.
Right.
I think for a lot of people, primary care was the initial problem. And, I mean, for me, I'm still with my oncologist because I have so many other issues. I have hematology issues, so my oncologist is an oncology hematologist. So I still stay with my oncologist, and so he kind of still monitors me, even though I'm 10 years out, but that's not everybody. And so many people had nightmares with their primary cares, and there are so many primary cares out there that are just so disconnected with anything to do, especially with colon cancer. There's almost like there needs to be a new medical designation as like a cancer survivorship primary care doctor or something. It specializes in people, because there's so many of us that are survivors, specializes in monitoring a cancer survivor. Because if you go back to our primary cares, I mean, I don't know, it's kind of a scary situation.
We're lucky in this, and we've got a pretty good setup. A lot of our patients aren't from around here. But I think, you know, I do help people match up with different primaries if I need to.
Yeah.
One of the things that I found useful was that when I really got that, I don't think I want to go back to the oncologist anymore, because I wasn't, I was cured, I got my diploma.
Mhm.
So my primary care doctor was like, oh, that's a question for your oncologist. Go to the oncologist, oh, that's a question for primary care. And then I thought, I'm not gonna go to either, I'm gonna go to my GI doctor, who does the colonoscopies. And I found that very helpful because he began to know me better and know my symptoms better, and he's the one that assures I get the colonoscopy every year, because there's a backlog of, you know, you have to wait 6 months, you have to wait, well, you know, the pain's there now, I want to do it now. And the GI doctor is the one who has still another bit of influence that'll get those tests through.
And that is I know patients feel like they ping pong a little bit. And communication is a huge issue. And that is a shortfall in medical care. You know, and that's where my role is helpful, because patients will call back and I can usually guide and help.
I've only heard of these types of resources at cancer centers. In California, I go to a national recognized hospital, but it's not a cancer center. It's just an oncology office. There's nothing like this that exists at all. There was no care plan. I'm just now 3 years out from being diagnosed, and every call that I make to my oncologist is call your primary care physician. So when I go there, he just looks at me like I have a cold, not looking at my full record. Oh, so you have colon cancer? Why don't you know this? I'm dealing with this every time I call or go in, but I'm always hearing the opposite from someone who's at a cancer center. Oh, they have a holistic approach. They were given a psychiatrist, they were given this, they were given a dietitian. I got a 15-minute phone appointment. You just told me don't eat red meat, which I haven't eaten in 20 years. That's not what I needed.
Right.
Is there, who sets the guide? There should be a standard established by the NIH of there has to be a care plan for every patient, regardless of where they're being seen at.
And that is really where this Commission on Cancer came in, but it's mandated to keep your COC accreditation
if you're a COC center.
But if you're not.
Right. So
There's no money.
right.
The centers that do this, the staff time is completely comes out of the center. There's no way to get this reimbursed. So like when I see a patient, right, I bill for my time. When Mary prepares a treatment plan summary,
I'm a bargain.
there's no
I'm free.
reimbursement.
Insurance
And
doesn't pay
so,
for it?
there's no payment for it. There's no payment for it. So patients like it a lot, primary care providers like it a lot, your team likes it a lot. Medicare has not, usually what Medicare funds, everybody follows, so Medicare has not fallen in line, partially because there's never been research that has shown this has improved outcomes, right? It seems totally intuitive, but if you look at the data, there's no hard data where we could say patients who got survivorship care plans had less ER visits or had
But the
earlier
dissatisfaction
recurrence.
of the patient should prove that.
Right, and it's pretty new in its infancy, and
It
I'm
should.
hoping that as these are implemented more, the data will bear this out. It's pretty new, you know, and, we've only really been hard at it for the last year. So I'm hoping over time the value will be seen. But
So another role for advocates
Exactly.
is to try to get this, it's under the
Yeah.
Affordable Care Act, you know, they mandate some things.
Right.
Have been any studies done on the long-term effects of chemotherapy and radiation, CAT scans, whatnot, in terms of, you know, not 5 years, but 10 years, 20 years? I mean,
Yeah.
among other things, when do I start getting my Social Security payments? I mean, am I gonna live to be 90 or live to be 75, based on all the radiation I've had and glowing in the dark? Is that, any studies? I mean, we see so many people.
Retrospective information on the CAT scans, there might be some new data, I reviewed this, when I was still in training, that looked basically at the radiation exposure, you went to survivors from the atomic bombs and that, there isn't any, I think that the risk is the most significant for, young women who have radiation, especially radiation to the breast, because there's a big delay in terms of potential increase in secondary malignancies. I'm talking about decades of 40 to 50 years, and it's a small risk. There's retrospective, there's one prospective. CT scans have not been around that much to know what the true risk is. I don't think for an average cancer patient it's a significant risk for the CAT scans we're doing. And I'm talking average based on the numbers that we're listing on the 60s. But for example, I have some patients in my clinics that have very slow growing tumors of colon cancer that require frequent surveillance. I have women in their 40s and 30s, so I can analyze those patients.
So it basically should not have a significant effect on one's life
As far as we know
expectancy.
right now, I don't know if you have any other information.
No, and we've actually done a study here looking at using lower dose CT scans, and I think people are thinking about that, but I don't think that there's a lot of any big risk from that. Now, getting radiation to your pelvis, you know, we do watch for secondary malignancies from there, but even so, 20 years later, that's still fairly rare.
Colonoscopies.
Mhm.
I have gone through 3 oncologists, just because I have. None of those oncologists on stage 4 have recommended a colonoscopy, even though I pushed for it. They said, stage 4, implication, you're gonna die anyway. There's no point in doing the colonoscopy. So I'm just, and it's not just one oncologist, it's now been 3 in the Chicagoland area that this is their, so I don't know if that's a standard of care or,
It's really the GI doctor
Yeah.
that.
oh,
that would
I know, but you have to,
follow it.
if I'm in a, you know, I have to get a referral, then my primary says, ask your oncologist, and the oncologist says, not necessary, but it's not just for me, I'm just wondering what the standard of care, because that's what it all comes down to, is if Medicare pays for it, everybody pays for it, my insurance has to pay for it, what's considered normal?
So I'll take that one. So I would say it's a case-by-case situation.
Okay,
If someone is getting active chemotherapy for colon cancer, the odds that they have something in their colon that wasn't treated by that, or that was going to cause them problems in the immediate near future, that would outweigh the risks of doing that procedure on chemotherapy. I think in my opinion, it doesn't necessarily make sense to do colonoscopies while someone's getting active therapy. But if you have someone who is a stage 4 NED or who is on a prolonged treatment break, I think in a very personalized discussion with oncologists that it is reasonable for many patients who get a colonoscopy despite a stage 4 diagnosis. But I wouldn't advocate it for it during active treatment.
Okay, and then you brought up something else, and it's just been something that I've seen and heard, and, you know, different oncologists, when you're stage 4 NED treatment, you're still on treatment for life, maintenance, they call it, and then other doctors don't agree with that at all. And, you know, when I've talked to the oncologists, they've said that there's really not any studies, real good studies that say whether this keeping chemo for life, this maintenance chemo versus taking you off of the chemo and then waiting to see if you get any additional metastases or any new cancers coming up. You know, chemotherapy can be a carcinogen all on its own right. It doesn't come without a lot of side effects that you need to be concerned about. So I was on NED, we talked last night, for 3.5 years, and I no longer am, but I was on maintenance chemo. So, and I really didn't like the fact that I was on maintenance chemo. Any idea when they'll have some kind of definitive?
So it depends what you mean by definitive. So there's
Well, somebody's gonna have some idea of really what they want
So there have been thousands of patients on clinical trials who we've investigated maintenance chemotherapy. And what we've found in those clinical trials is that as a large population of patients doing maintenance chemotherapy or chemotherapy beyond resection for a stage 4 cancer patient does not improve the cure rate, meaning people aren't cured because of that extra chemotherapy. And in patients who aren't even NED, but their disease is in kind of remission or has been kind of knocked down significantly with chemotherapy, and then they're switched to a maintenance type approach, that maintenance approach doesn't improve how long people live. It feels like it should, but when we've studied this in large populations of people, the maintenance approach hasn't shown to make people live longer. Where the benefit has been that we've seen is that if the cancer is going to come back, that maintenance therapy might, in a number of months, help delay the time to when the cancer was going to come back. But it doesn't appear to overall improve how long people live or increase the number of people who are cured when they've had resection of stage 4 disease.
So why is it that doctors still would encourage people? You know, I mean, a lot of cancer sites, and I see a lot of, I see more maintenance than I see you later, let's monitor this every 3 months.
So it comes from a couple things. One is we think that there is potentially advantage to that disease-free survival benefit, or at least disease control survival benefit. In addition, there is some concern that when the cancer comes back, it could come back in places that would cause symptoms, and so maybe that maintenance chemotherapy can help prevent those symptoms from coming. But there's not a big, overwhelming kind of primary endpoint of survival or cure rate that would indicate that it's necessarily beneficial across a large population.
And some people call Optimox dosing when you're on the lighter dose chemo, maintenance chemo, so we just need to make sure we're talking about the same thing. Dusty's talking about when patients have been rendered NED.
The lighter dose chemo.
Preventative chemo is
Yeah.
not helpful, but I sometimes refer to it as maintenance chemo when I put somebody on FOLFOX and then we get everything shrunk down and then they're on just Fiberfuse or.
Yeah, no, I'm talking
That would be-
cases, NED,
Yeah.
and NED
I just
for
wanna make sure
a long period of time, and they're doing this maintenance chemo. I did maintenance chemo for 3.5 years. And I know people that have done it longer.
So we're going to be talking about side effects and survivorship over lunch and part of a focus group, so I think this is going to be good discussion for us, and I know everyone's going to be around. I want to make sure you have enough time. I'm like the least time-sensitive person normally, so this is really an awkward role for me to be like, all right, well, look at the time. So, but I do want to give Mary the opportunity, because I do want to make sure everybody has, Sharon and I want to make sure, Dusty and team, we have enough time for lunch, and then we really want to collect some of the information that we're talking about too, and really open it up for discussion with kind of a quasi-focus group at lunch. But while we're doing this, I want you guys to really be thinking, because I think part of what we're talking about are things that Fight CRC, you all, investigators, researchers, everybody here needs to really think about. How are some of these questions and this thought going to move into action? So we can talk about these things, we can what have you, but hopefully 2 or 3 years from now, we're talking about that there are enough outcomes from the treatment summary care plan to show that they were effective and that someone should pay for them. This isn't going to happen on its own. So let's be thinking about like what are really good ideas, questions that you would either like to sit in a research panel. If there isn't a research study or an opportunity, what do we need to be thinking about? And even if it's on the other side of the Fight CRC house, even like some of these reimbursement things might not be completely a research issue, but maybe there's something that even the legislative side with what we're looking at for different opportunities, we need to also inform the legislative agenda as well. So what I want you guys to do is please really be thinking about some of this intangibles. What can we be proactive about? We're going to discuss some of this in the morning, but I want you to write ideas here as you think of them. So let's put this here so that we're really thinking about our role in all of this stuff that needs more work. Okay, go on, Mary.
So getting back to talking about what we talk to patients about with prevention and healthy lifestyle, a lot of diet questions come along. We talk about, and we only go really by evidence-based practice. You know, what do we know for sure? And so we talk about the 2/3, 1/3 rule on the plate. 2/3 fruits, vegetables, whole grains. 1/3 animal proteins. Try to limit red meats and avoid cured meats. For sure. Limiting sugar. Patients want to know, does sugar feed cancer? That is one of the hottest topics. And we used to say, oh, no. Now we say, well, you know what? It's unclear. The role is a little murkier now, and we're thinking about that more. We do know that high sugar diets and empty calories cause weight gain and obesity. That's a higher inflammatory state for people, and we know that that's not a great condition for cancer, this inflammation. So we really try to work on healthy BMI. We've done lots of studies, and so people that are at an appropriate weight, you know, diet may not matter as much. But soy, did you soy or not soy, we say in moderation, and organic or not, makes no difference in studies. Wash your fruit well, wash your veggies well. Exercise, again, getting back to the healthy weight and BMI, these are the guidelines. So 30 minutes of moderate activity 5 times a week. And the role of weight-bearing exercises is coming into play too, that's really good for our patients, especially for bone health.
And fatigue.
And fatigue, yeah. And there's a lot that say exercise helps with sleeping at night, stress reduction, and fatigue levels. So, what do we talk about? Follow up with the PCP for primary health care. Stop smoking. We really key in and try to help people with that one. It's a challenge. Aspirin. We recommend full-strength aspirin and tericlomin. But if the patient has other reasons that is too much for them, bleeding, ulcers, things like that, we may say a baby aspirin. Again, bone health issues and keeping up with flu shots, vaccines, and the hospitals. So, no binge alcohol, limiting alcohol. Yeah, but in Wisconsin, we are tailgaters. And, you know, we love our Packers and our Badgers and Brewers, but really, you know, having focused talks about how much alcohol.
But no vitamin D. Vitamin D is not a recommendation.
Well, it is in general. So they've done studies on vitamin D in cancer, and so far it hasn't. There's not.
Colorectal, there's a little bit of data about what your vitamin D level was at diagnosis predicts outcome. We don't know if doing vitamin D supplementation after diagnosis can impact outcome.
So we really look at it in terms of calcium and vitamin D for bone health. So I do have some recommendations that I give patients that I would for anyone. Late treatment effects. A lot of our folks have had surgery, and there's bowel function, things that we need to talk about, increased frequency and urgency. A lot of people that have that had their rectum removed will get some phantom pain. Chemotherapy, fortunately, the chemo, go ahead.
You're missing something.
Mhm.
Cognitive dysfunction.
What's that?
Cognitive dysfunction. Chemo brain?
Yeah, and the jury's out on chemo brain. Dusty?
That's the problem.
I'm looking right at
That's the problem.
You're like, but the jury's in on Dusty.
So, clearly I have chemo brain. Every patient who's ever had chemo, including myself, feel the effects of what everybody calls chemo brain. Whenever anyone has really tried to study this, the tools that we have to assess it don't allow us to pick up a change before and after people have chemotherapy that is different than before and after people are diagnosed with cancer in and of itself. And so,
You're talking about colorectal. Because in breast, I think we have shown it.
Well, I've asked Amy Tabark about that. They don't put it on their survivorship either. Because she said, you know.
so I agree with everyone in the room that yes, it is something that everybody talks about, everybody senses. When we try to actually study it, at least the tools that we're using to study it, it's challenging to actually quantify.
And honestly, it is. And they've done a lot of studies on PTSD in cancer patients. It's fairly significant. And so it's hard to separate what's from what, you know? And so there is that component to that. When people are under great stress, you're not going to be thinking at your highest level of functioning.
But even when the stress after the actual diagnosis ends, the chemo brain still lingers. So it needs to be recognized.
And I think we do try to do that on case by case because everyone is different.
True.
You know, and so I think that's a thing as a clinician. You're going to talk with your patient, and if we're looking, you know, and you're telling me that I am really having problems, we'll try to get to the bottom of it and do what we can. You know, sometimes that's doing some testing, or sometimes it's let's talk about your level of fatigue because I think that's a big one that impacts patients' abilities. Are you sleeping? You know, and how are you doing? Because I think that affects your cognitive
But the
function
fact
as
that
well.
it's not up here, see, the fact that you go, as a patient, you go to your oncologist and you're not being heard is one issue. But then the
Yeah.
fact that it's also not being recognized is another issue because another patient thinks, am I really crazy? Because I've been there. I'm on my third oncologist who has nothing to tell me about chemo brain, but I'm experiencing it every single day.
You know, and I think if you were to come to one of our providers or myself with that concern, we would listen. And we do, even if it's not up there, we know, we have it in the back of our heads that a lot of patients experience that. So we try to work through it, you know, as best we can.
I think what she's saying though is a lot of those things will apply to people though. So
Right.
if chemo brain applies to a lot of people, then why is
So
it on the list?
neuropathy does,
Mhm.
it
Right.
should be on the list.
That's, I know what you're saying, why is it recognized as an issue? That's,
Regardless if it's 10% or a 0.5%,
Mhm.
it's there, it exists.
What were you gonna say?
So what we know about chemo brain, so I agree with you. I think it should be on the list. After fatigue, it's probably what I get asked about the most from patients. What we know from breast cancer is that it seems to be short-term more than long-term memory. We know 5FU is a culprit, which is pretty much in every colorectal cancer patient regimen that's getting these plans. So mechanistically, 5FU can do it. 6 months of chemotherapy, which most people get, certainly long enough to get it. Short-term more than long-term. Exercise and time seem to be the biggest mitigators. So I counsel people, and then, you know, as we age, our memory gets worse too. So we're kind of having two competing things. But exactly as Mary said, we want to treat depression, treat PTSD, make sure you're sleeping, adequate nutrition, and then counsel you through. Exercise is critically important here. I mean,
You brought up a
I
good
cannot
point
overstate
in
that.
terms of age.
What?
You bring up a good point in terms of age. However, the demographic for colon cancer now is younger people are getting it. So if you have now a 25-year-old versus a 55-year-old, well, this person may have issues because they are getting older. This other person who was 25 was fully functioning.
So
And
not-
now can't do that any longer.
Right. So,
It's a
I mean, not to be
difference.
depressing, but starting at 30 is when our we start to atrophy in our brain, which which is totally. But that is kind of the break point. But I hear what you're saying, that people are, it's affecting their everyday life, and so we need to talk about it. But that's the state of the science right now.
And specifically in colon cancer, it hasn't been studied
Yeah.
in the younger population.
No.
And that's
Not at
something
all.
that needs to happen.
So put it on the list.
And you bring up a great point in that we do have younger patients now, unfortunately. So that's why this stuff is even more important, because people are
Right.
living longer with these effects.
Yes.
Exactly. Yep. Radiation is not without its issues for sure. Scarring and strictures, pain, chronic diarrhea, bladder is often affected. Fatigue. So I have patients, if it's really a problem, keep a diary, look at your schedule, maybe we can work through some of the things. Activity certainly helps with that fatigue, so we'll talk about exercise again. And I think people too, if you haven't been an exerciser, people think I have to go to the gym. Clearly not. Walking is fantastic, you know, and I think starting small and realistic really helps patients, because they look at this and think, I have to change everything. Maybe let's focus at one thing at a time. So part of my role is making change manageable for patients. You know, I'm taking one thing, little things here and there make a huge difference. Those 3 P's of prioritizing, planning, and pacing yourself. We do a lot of sleep, talking about sleep hygiene routines, and that certainly helps. But now, lots of concerns too with fertility and sexuality. And I spend a lot of my time discussing those issues with patients, because it's a huge impact on people's lives. And the treatments that we give, it impacts that. And permanent ostomies, we have support groups here. And there's also, I know Fight CRC has a great resources for people with permanent ostomies as well.
How, you know, I come from an area that does not have a cancer or, you know, a university or anything, but when I have a permanent ostomy, and trying to get anybody to help you with it is like ridiculous, because the surgeon does, you know, did it and they're gone. I mean, my oncologist obviously doesn't work with it. And we have these wound clinics that you can never get into because you have to get a referral. By the time you get a referral, you don't have the issue anymore. So I'm just wondering how your guys' follow-up is here, because in Arizona it's awful. I mean, we have support groups, but that's.
We do have dedicated ostomy nurses here. And as the coordinator, I'm getting to know these folks very well. And, you know, now I can say, hey, I'm gonna send a patient over to you. And, you know, and in our cancer center, we have a nurse, that's the ostomy resource nurse that goes to all the education meetings and things like that. So I agree with you that back earlier in my career as a GI nurse, it can be challenging getting supplies, getting the right fit, skincare issues, blood. Yeah.
Inpatient,
nurse
it's
helps.
fine, but it's the outpatient's the problem.
I think
Yeah,
we've
and
made
it's
enough
still-
noise.
It's still a problem.
But it's getting better.
Yeah, I mean, as an oncologist who has a permanent ostomy, I raised a lot of stinks when I had my treatment, because basically I was sent out with a home health nurse that knew very little
Right,
about
me
what an
too,
ostomy
exactly.
even was. And so I've actually been proactive in talking to our surgeons about how to make this process better. And so I think through the education with the ostomy nurses have now become a much better resource for our patients than they used to be.
Well, and I've had to be a little bit, you know, like a dog with a bone with them as well. You know, if I have a patient that I'm not happy, you know, with the advice, we just keep pushing till we get a solution. So I think it's hard in communities that don't have those resources. I agree.
What I would love is if we could find some ostomy nurses who actually have a permanent ostomy. I think that would really help.
The
You're right.
understanding of it. Sure.
Yeah, even calling the supply companies, some of those people need to have an ostomy too. That's a whole other
Well,
issue.
maybe an ostomy nurse, that's a certification, right, on top of a wound care?
I think that you,
So that could be something they could be advocating for.
right. And I think that not every ostomy nurse is certified.
Right.
But I think here we really push for that to be certified in each specialty. So additional concerns, and this is another part of what I counsel people with. You know, I have a box on the floor.
We kind of go through and say, if you have any of these things, these are the things that we're here for you to help with. These are the things that we're so focused on the physical aspects that we need to remember that what we can tell people, what other additional things we can help with. Emotional difficulties, we have cancer health psychology here, we have social workers and we have nurses and our physicians, so we try to do the best that we can with needs. Fear of recurrence, that's where the support group that I have, I think people help each other more than I do oftentimes. Financial toxicity in these days is a big issue. Getting social work involved, loss of the safety net of coming and having chemotherapy and seeing us. I think knowing that you have a surveillance schedule, here's what it is, we're not just kicking me out, is helpful for people. And then goal changes and changes in relationships. I think people tell me, you know, when am I going to be back to where I was? And that may not be, yeah. And, you know, there's that phrase, new normal. Some people like it, some people hate it, but however that is, you sort of have to refine your footing in life. What can patients do with these things? And I try to tell people, let's focus on what solutions do we have? What are the things that you can do to help take care of yourself? Talking to other people, talking with your family, having good health habits, giving yourself time to get over all of this stuff. Getting support, finding ways to relax. A lot of people like Tai Chi, yoga, mindful meditation. We have those classes that are available. I think that all helps. But I think providing patients with resources to sift through what is helpful and what isn't. And I love this quote. This is from a cancer survivor's blog. In battling cancer, we engage in treatments that are harmful and toxic, but ultimately life-saving. Only after the war do we realize the high toll it took on our bodies. I think, you know, when you're going through this, it's sort of bring it on. I need to do what I need to do. And our job is we want to give you the best chances. But then, you know, you have to think of the toll it's taking. So I think the movement in survivorship, we're getting better at thinking about that and addressing those patients go on in their journey. Any other questions?